My name is Jennifer Roesch, and I did my project on safe staffing levels. After completing this presentation, the learner should be able to define components of safe staffing in the nursing profession and the role it plays in patient and family care. They should be able to identify different concepts that are used to establish safe staffing. They can demonstrate an understanding of the nurse leader's role in safe staffing and be able to discuss multiple factors that affect safe staffing in hospitals today. The course outcomes that I accomplished during this project was the ability to examine strategies for nurse leaders to ensure safety and quality of care, to utilize data management informatics to plan nursing staffing and budgeting, evaluate the components of an effective performance appraisal for nursing staff, and apply knowledge of leadership, management, and collaboration principles to the practice of professional nursing. So what factors do we need to consider when establishing safe staffing levels? We need to make sure that we have the right number of nursing staff on the unit that is needed for the patients that we are caring for. So different units obviously have different staffing ratios, but just making sure that they have the right number of staff that they need. Right qualifications of the staff and experiences from the nurses. So if we have 8 new grads, we don't want to put them all in the same schedule. We want to make sure that we have a good mixture of experience so that way if an event does occur, we have the right qualifications and staff available. Are we able to respond in emergency events? I noticed this a lot in the ER when we had enough staff to care for the patients that we had at the time, but what if there was a priority 1 that came in? Are we able to have enough staffing to care for that priority 1 patient as well as our other patients in the ER? We also want to make sure we have enough staff to help prevent hospital-acquired complications such as like pressure injuries. So do we have staff to turn the patients every 2 hours to help prevent these injuries from occurring? We can show that we have safe staffing levels by evidenced by positive clinical outcomes. So are we seeing less pressure injuries? Are we seeing good nursing care occurring because we have enough staff for that safe staffing levels? Additionally, we also want to look at satisfaction of care and costs also. So if we have enough safe staffing levels, obviously patients are going to be more satisfied because they're going to have positive clinical outcomes showing. And then we're also going to see lower cost due to less preventable hospital-acquired complications occurring, shorter stays in the hospital, and things like that. The ANA in 2012 stated registered nurses should be provided a professional nursing practice environment in which they have control over nursing practice and autonomy in their workplace. There are a few legislative rules in safe staffing that are already in place. Hubert 2018 explains 3 models of state staffing levels that have been implemented in some way. One of these is the nurse-driven staffing committee to create staffing plans. So there's actually committees that get together to make sure that they have adequate staffing plans and procedures in place. Another one is a state mandate specific nurse to patient ratios. There's a handful of states that have implemented this, such as California, where they have set ratios depending on the unit for nurse to patients ratios to be set. The other one is also to require disclosure of staffing levels to the public. The Registered Nurse Safe Staffing Act of 2015 was major because it required Medicare participating hospitals to implement staffing plans. Like I mentioned before with the committees, they also required the appropriate number of licensed professional staff on each shift. And then they also looked at the characteristics of the patient and the hospital unit. So they looked at the acuity levels as well. But why are we still having complications with staffing? The pandemic of COVID-19 definitely had a negative impact on our nurse staffing safe levels. One of the signs that I noticed on a California Nurse Association member during the pandemic is we don't need pizza, we want ratios, safe staffing always. And this was in regards to the California Department of Public Health trying to revoke their nurse to patient ratios during COVID-19. The nurses did not like this. They wanted to make sure they had safe staffing. They didn't want to be overworked. They wanted to make sure that patients were receiving the care that they needed. So these increased nurse to patient ratios were happening, as well as having higher acuity patients. So we were having more patients coming in that nurses had to care for, as well as these patients were sicker. So this is leading to higher nurse burnout, unsafe work conditions, higher nurse turnover rates, and then poorer patient outcomes, as shown by this study here. So what can nursing leadership do to help with these staffing issues and to implement safe staffing on their units? First, they need to establish an appropriate staffing management. There's different types of staffing that they can use depending on their unit and what they think is most appropriate. One of the types of staffing is the acuity-based staffing. So the staffing is established based on the acuity of patients and the resources that the patient needs, instead of just this patient or this nurse can have this many patients. They're going to look at how sick is the patient, how many resources does this patient need, and then develop staffing based on these. This here is Edwards is an example of a chemotherapy clinic that implemented acuity-based staffing. When they did that, they showed improvements in wait times, capacity, infusion hours, chair use rates, patient visits, average infusion length, and patient satisfaction all improved. If you look at the graph that I have here, so before they implemented the acuity-based staffing, their wait time and the chemotherapy was lower. And then once they implemented the acuity-based staffing, their wait time had improved. And then also with the comfort in the area, they showed increased comfort for the acuity-based staffing. There's also fixed staffing. This shows there's fixed projected maximum workload requirements. They base this off of productive time, non-productive time, which is like non-direct patient care, work time, paid full-time equivalents, and hours per unit of service. So they'll take all of these measures and then the amount of patients that they have, and they'll figure out a maximum workload and they will staff that way. So nursing leaders need to know which type of staffing is appropriate for their unit and what works best for safe staffing. This here is a video clip of a safe staffing initiative. It was a ward in Ireland that implemented the acuity-based staffing model, and then to determine the appropriate safe staffing levels for their unit. They looked at how sick their patients were, what nursing staff was required to help care for this patient, and they found that the acuity-based staffing did help improve patient outcomes and decrease nurse burnout rates. So this is a great video to view when you get the opportunity. So additional roles and function of the nurse leader in safe staffing. Like I said, they need to implement appropriate nurse staffing relevant to their nursing unit. So working on their staffing management, are they going to base it on acuity levels? Are they going to base it on full fixed ratios? And then also, do they have the right nurse staff qualifications and experience on the unit at the time? A lot of the concerns that we have with safe staffing levels right now is just there's not enough staff available. So although the nurse leader may want to staff the unit appropriately, they may not have the staff. So recruiting staff is one major function and role of the nurse leader in safe staffing. Also nurse retention, so keeping nurses that they already have by acknowledging hard work, giving awards, promotions, things for when nurses are doing a great job, listening to nurses' concerns, and implementing new changes to address those concerns when needed, and then also decreasing turnover rate. So the study here shown in 2020, they showed that a lack of preceptor education, as well as workload stress and inconsistency in tutoring skills, were all reasons they had a high turnover rate. So the nurse leader working on educating their preceptors, working on decreasing workload stress, and increasing tutoring skills on different things in the unit will help to decrease our turnover rate as well. So quality and safety in healthcare when it comes to safe staffing levels. Multiple studies have shown that poor staffing levels led to increased hospital-acquired conditions, such as our CLABSIs and CAUTIs, and then also the HAPIs are pressure injuries. They've also shown with poor staffing, there is a lot more patient falls, there's more readmissions, higher mortality rates, and missed nursing care. So not turning patients or not changing briefs or anything when needed. Additionally, lack of staff also caused staff and patient injuries, caused higher nurse burnout rates, increased turnover rates. So obviously with safe staffing, a lot of these are going to be switched over. We're going to have less patient falls. We're going to have less readmissions because we're able to sit and educate our patients more about their care when they do go home. And we're able to give better quality nursing care. The Joint Commission is one area where they can come to the hospitals and look at the quality of care and patient safety. They look at the verification of nurses' qualifications. They ensure that there's an adequate number of staff to meet all of our patients' needs. They also assess licensures, experience, and continuing education on the unit. So they do look at like what qualifications do the nurses have? Do they have additional qualifications besides just their license? And then also their continuing education to keep up with that throughout their nursing profession. Studies also shown that magnet status hospitals have shown higher quality of care. And that's why a lot of hospitals want that magnet status because they do tend to show higher quality of care and better patient outcomes. So what is interprofessional practice and how does it work with safe staffing? So nursing makes up about 40% of the healthcare personnel. So there's 60% of the healthcare team that is not nursing. So we need to communicate well with them. So communication is a big thing. Team approach is a big thing. O'Leary, a study showed for centennial events, a lot of the times these occurred because of failure of communication between surgeons, patients, and staff. They showed a lot of wrong side surgeries being implemented because of failure of communication. So safe staffing, making sure that they're communicating back and forth is a huge thing. Do we have enough resources? Are we staffing respiratory therapists on site in case we have events where we need the respiratory therapist at the bedside? Do we have PT and OT available for these patients that are getting up the first time after surgery? These are all safe staffing measures. Interprofessional education programs are available to help with communication and for increasing knowledge and skills of the team as a whole. Nursing productivity should take into consideration patients' needs, nurses' competencies, availability of resources, and services provided. So this links in with interprofessional practice because do we have these other team members to help with these specialties that we need for these patients? Additionally, collaboration with other health professionals, we're going to look at, do we have adequate physicians and mid-level providers to assist with patient needs? Are we addressing unit maximums to ensure safe staffing levels? So I've seen this a lot in OR. If they're scheduling too many elective surgeries, but they don't have the staff to recover them or they don't have beds for the patients to go to, these are safe staffing levels that need to be addressed. And working interprofessionally to tell them like, hey, we don't have enough recovery nurses for you to be having these surgeries. Do we have this available staff to provide services and support such as wound care referrals or PT and OT like I mentioned before? And then are we utilizing our nursing assistants to the best of our ability? In conclusion, research has shown safe staffing levels brings about positive patient outcomes and a decrease in hospital-acquired complications. COVID-19 has brought attention to the public on the importance of safe staff nursing. There are multiple measures that can be put into place to ensure safe nurse staffing by nurse leaders, and nurse leaders have many roles to ensure safe staff on their units. Nurse organization meeting. I attended a wound ostomy continence advisory meeting. The meetings involved wound care nurses at 7 different Beaumont sites. This year they had to do the meeting virtually due to COVID restrictions. However, I was able to sit down with 2 wound care nurses at the Beaumont Dearborn site, and we worked on the Teams program to do the virtual meeting with the other nurses. It's held once every month for approximately 1 hour. During the meeting, I noticed that they discussed issues about budgeting and product uses. So they talked about different products, how good these products were, and then their cost. So they were trying to determine which products that they wanted to use based on cost and how effective they were. Um, I also noticed the nurse leader delegated some tasks to other nurses because she didn't have the time to do these tasks. So she delegated another nurse to work on the times for their meetings. So I thought this was interesting because we did discuss this in class about nurse leaders and proper delegation. They also discussed root cause analysis on why some of these wounds were occurring on the unit. So I thought that was interesting because root cause analysis is mentioned a lot in this course about how to determine what nursing care is lacking and what they can do to help implement these new measures for these wounds to not occur. They also talked about taking pictures of patients' wounds on admission and whether there was legal measures about this. So they wanted to make sure that pictures are documented so that they know what wounds they had when they got there, but they also wanted to make sure that there wasn't any legal allegations for having these pictures being taken and posted on these patients' records. So overall, I thought the meeting was really interesting. I liked how they talked about a lot of different things that we had in this course, and it was nice seeing different nursing organizations like the Wound Ostomy and Continence one that we are able to be a part of if we want to join. So overall, I really liked this experience. And here are the references that I used for my project.